Good afternoon, everybody. And I will present to you a valve technique. This is to say, the video-assisted anal fistula treatment, a new concept to treat the fistula, a new method to treat the complex anal fistulas. I divided my presentation in 6 points. The preface, the kit, the valve phases, the follow-up, and the conclusions. What are the causes of the fistula recurrence? We know that the most important point is to correct initial treatment. In other words, the first visit and the first operation. Many others have identified some critical points. Use of the metallic probe during the first visit, at the beginning of the operation, identifying the correct internal opening location, and the possible presence of chronic abscesses or secondary tracts. The literature reports that 20% of recurrences, even in simple fistulas, are because of a failure to identify these secondary tracts. So, valve technique has at least 4 unique features compared with the other techniques. First, and the most important, the fistula is always treated visually, so we can more easily find the possible secondary tracts or chronic abscesses. Second, the internal opening is precisely located and closed. Third, there are minimal surgical wounds on the perianal skin, and finally, no damage to the sphincters is caused. Let's talk about the kit. It includes a fistula scope manufactured by Castors, a monopolar electrode, an endobrush, a semicircular or linear stapler, and an half a milliliter of synthetic chanacrylate, the Glubrand 2. The fistula scope has an optic channel and also an operative and irrigation channel. The fistula scope has 2 tabs, one of which is connected to the 5,000 milliliter bag of glycerin and mannitol 1% solution, which allows a better and faster internal fistula wall cauterization. It includes, as regards the diagnostic phase, its purpose is to correctly locate the internal fistula opening. We insert the fistula scope through the external opening with the glycerin mannitol solution already running. So the fistula pathway clearly appears on the screen, but sometimes the external opening is surrounded by very tough scar tissue, so we often have to remove this in order to allow an easy entry for the fistula scope. We put the fistula scope against it and wait for the glycerin mannitol solution to open the fistula tract. Then we simply follow movements left, right, and up, down, exactly like driving a car in a tunnel. Finally, you will get at the end of the fistula pathway, which is the internal fistula opening. The fistula scope usually goes out through the internal opening, but sometimes the internal opening might be very narrow. In that case, its location is found by viewing the fistula scope light behind the rectal mucosa. At this point, we put 2 or 3 stitches on the internal opening in order to isolate it, but not to lose it. And now we talk about the operative phase. Purposes of this phase are the fistula destruction from the inside, the fistula cleaning, and finally the internal opening closure. We destroy the fistula using the electrode passing through the operative channel on the fistula scope all the time visually. We complete this phase centimeter by centimeter from the internal opening to the external opening, cauterizing all fragments of the weightish material adhering to the fistula wall, not forgetting any accessual cavity or any possible fistula branches. We remove the necrotic material by an endobrush, again visually. The continuous jet of the washing solution also assures a full elimination of the waste material into the rectum through the internal fistula opening, first isolated by stitches but not closed yet. So, let's go back into the rectum. The assistant maintains tension on the threads with a straight forceps so as to lift the internal fistula opening into the shape of a volcano. We go on inserting the stapler at the volcano's base and completing the mechanical cutting and suturing. This procedure might be performed by a semicircular stapler or linear stapler, reticulator or not, which depends on the internal opening position. The final result is simply a scar in the area where the internal opening was. But when the internal opening tissue is not sclerotic and allows you to make a god volcano, the stapler uses better. But if the internal opening tissue is too rigid and sclerotic, the use of the stapler might be difficult. In that case, we can make by hand a cutaneous mucosal flap. In any case, the internal fistula opening must be closed. Do it as you like, but do close it. At the end of the operation, we insert an half a milliliter of synthetic chanocolate, the Glubran 2, by a tiny catheter immediately behind the stapler or flap suture in order to reinforce the suture itself and ensuring the perfect opening closure. The Glubran 2 must not be placed into the fistula tract because the fistula pathway must be open to allow the outflow of the secretion in the postoperative time. As regards the follow-up, from May 2006 to May 2011, we operated with the VAFT on 136 patients. Most of them had already undergone surgery for complex anal fistula. We instituted a 2, 6, 12, and 24-month follow-up. But I think you will agree that to be sure a fistula is completely healed, it is better to wait at least 1 year. That's why we've decided to consider the follow-up results after no less than a year, above all when the fistula is complex. Therefore, we started to evaluate the results on 98 patients from 6 months after the operation. 27 females, 71 males. I'd like to underline that we are operating on patients who have already been operated on 8, 9, 10 times, some of them with a colostomy. As to complication, no major complication occurred, and all patients were discharged on the same day as the surgery. The pain deserves a separate discussion. In most cases, it was acceptable, both in the early and the later postoperative time. As you can see in this graph, 21 patients did not need any analgesics. Only 8 patients, about 8%, needed ketorolac trimetamine for a week. That is because the suture line is only about 2 centimeters long. These results demonstrate that there is not any correlation between the suture position and the pain. Primary healing was achieved in 72 patients, about 74%, within 2 or 3 months of the operation. 26 patients, about 27%, didn't heal. 2 of the patients didn't continue with the follow-up. 19 of the 26 underwent VAFT once more, and the other 5 underwent only the chanocolate injection. 9 of the 19 patients reoperated by VAFT healed, 6 have a new recurrence, and the other 4 are still under observation. The 5 patients who underwent the chanocolate injection have had recurrence. In this graph, you can see that the percentage of the patient healed after a year is high. It means if the patient passes a year without any problem, he has a very high chance of healing. In conclusion, VAFT had the advantages of VAFT technique are evident. First of all, the direct vision that represents the principal one. And then there are minimal surgical wounds, correct location of the internal fistula opening, a key point in all fistula treatment, and the possible secondary tracts. There is the certainty to have completely destroyed the fistula from the inside. There is no requirement to know the type of the fistula before, because we operate from the inside and no damage is caused to the anal sphincters. So the patient does not have any problem with fecal incontinence. Moreover, the patient has no need for medication and they can start walking again after a few days. It's no use performing preoperative exam, because the VAFT has got a diagnostic phase and the final VAFT is performed in the surgery. In conclusion, and in my opinion, it is also very important to consider the patient point of view. What does the patient want? Look at this work published by Alice. For the patient, it is of greater importance to minimize the risk of sphincter damage, to avoid large wounds, the presence of acetone, and a lot of secretions. In conclusion, you have to consider that if the patient doesn't heal, you go back to the 0 point. You have not done any damage, and above all, you can repeat the VAF procedure. I suggest that you use the fistuloscope for all types of fistulas, both simple and complex, as a diagnostic instrument to identify any possible secondary tracts. In the case of simple fistula after fistuloscopy, you can remove the fistuloscope and perform the operation you want. A group of Dutch colleagues has recently published this work. They report that the fistuloscope as a diagnostic instrument is more reliable and accurate than magnetic resonance. In 2 of 12 cases, the fistuloscope has shown the presence of secondary tract, which the magnetic resonance did not show. This is an example of a VAFT result after 1 and 2 months. At the moment, the VAFT technique is used in many countries. Our courses are attended by doctors from all over the world. With some of them, we are forming an international study group in order to standardize the operation and to compare the results. If you are interested in attending the VAFT course, please get in touch with your car stores agent or download the registration form in this website. We'll be happy to see you. Have a good look. Thank you very much for your attention.
Any questions? I think that's also a very interesting technique. This scope was developed by you guys with Stotz.
Yes.
And it's a flexible scope?
Yes, it's like an pediatric uteroscope modified, and the idea is to insert an optic channel to see the fistula tract. So yes, by Karl Stotz.
My compliments for your technique, I know very well, but what I think is, in this case, before to start with the scope, do you test with the probe before the tract or not? Just to make sure there is a between the external opening to go straight to the internal opening. And then in this case, I think it should be better a flexible scope, just instead a rigid scope, because sometimes it's difficult to follow the tract.
So, yes, it's a good question, and the problem is the anesthesia. The anesthesia is or general anesthesia or spinal anesthesia, yeah. Because the surrounding tissue allows the spinal anesthesia allows the surrounding tissue to relax the surrounding tissue. So the concept of rigidity of the fistula scope is patented because it's voluto, come si dice, it's
necessary. Okay.
It's necessary that is because when you enter the fistula scope and you can put inside the anus your finger, and this maneuver allows to go straight to the fistula, okay? Like you use the colonoscopy when you perform the colonoscopy, okay? The fistula goes straight, okay? This is a very important concept. First, and the probe, no, I don't use any probe because the concept is to see, to show, under vision, okay? And the probe is very, very dangerous, in my opinion, and it's not only in my opinion.
No, probably what the people wonder is that sometimes the fistula makes a very narrow curve, and sometimes the size of the fistula is really smaller than that scope. Sometimes you need silver. They're very flexible to be able. And this is not a straight.
We tried with the flexible, like come si dice, ureteroscope, pediatric ureteroscope, but it's very difficult to modify the tissue, the surrounding tissue, and it's not possible to curve. Yes, it's a very important this point, and in this case, the problem is to identify the internal opening, okay, and when you enter and you have the surrounding tissue very, very relaxed, so it's not easy, but it's not impossible to
straighten it up.
To straighten it yet, because I have a handle, a removable handle, and allows these maneuvers. The handle, because
okay.
you can force the tooth.
The vision help you to go
yes.
Okay.